All right, so we have some people here, and I hope they're going to ask me some questions, and I'm just going to wait a couple more minutes just to see. Um, Remember, where you ask the questions. Oh, I remember I have to do something here. Hang on. I have to open the chat thing. Give me 1 second. Don't pay attention to me. Oh, I think I figured it out. Okay. Hopefully I can see that. Maybe if someone has that question, if there is a question, put it in the chat so I can see if it's working at least, but it should be working. I'm hoping it's working. Okay. I just saw one, so I know that that's working. So I'll go ahead and answer that question. And again, anyone that's here, and we have about half the participants have come over here. So just remember, no one sees your name. No one's going to mention your name. These are completely anonymous. And whatever questions you might have, if any questions you can think of, anything, this is also getting recorded and getting put on my website. So there won't be any stupid questions here because whatever you're asking, trust me, everybody else has the same questions. So I'll just start answering them. You fire away, and I'm just going to go down the line. There was a question about, I think somewhere this patient had read that potentially Flomax, which is called tamsulosin, you remember that was an alpha blocker, maybe sped the progression of Alzheimer's. I had not heard that. I mean, I could sit here while we're on together and try to Google that, but I actually had not heard that. Oh, and you know what? I'm really glad someone brought something up here about tadalafil. Thank you for that, because I forgot to mention that as a legitimate medicine. I think there's a lot of, the main thing, I think that question might be getting confused with another class of medications that's for overactive bladder. Overactive bladder is a part of enlarged prostate. I urinate frequently, but overactive bladder is just a function of the bladder being overactive and it wants to urinate frequently. So it is true. Those are called anticholinergics, by the way. Anticholinergics. Examples might be Vesicare, Ditropan, things like that. Myrbetriq is one that is doesn't mess with that. Those have been linked to potentially, the question is, does that speed dementia or Alzheimer's, that kind of thing. So not alpha blockers, not that I know of. Yes, older anticholinergics. That's actually one of the big selling points of some of the branded expensive ones now, the main one being called Myrbetriq, is that it doesn't work that way and it doesn't affect that. So that's the answer. Anticholinergics can be associated with speeding up Alzheimer's, so we try to avoid them. Although there are some anticholinergics that don't do that. It's called Sanctura. Next question is it true, and thank you, keep them coming, is it true that Cialis can treat BPH? And now that it's just us and it's not, I don't have to stick to those slides. I can tell all of you honestly that I have to stick to those slides, and in some ways they're a bit outdated. There should have also been the category of Cialis. So let's talk about that. Cialis is called tadalafil. Cialis is a medicine that was designed to treat erections. It's very similar to Viagra. Cialis has a long half-life. That's why they show the bathtub and spontaneity, because it lasts longer. Back in the day, erection medications were exceedingly expensive, $60 a pill. It was just a highway robbery. And what they found with Cialis is that men were saying they could urinate better in the clinical trials. So they lowered the dose. They made it daily, 2 different doses, 2.5 or 5. Mostly we always use 5. And it does help you urinate. Back then, it was a way to get erection medicines treated. So there was a period of time where one of the most common urination medicines was Cialis, because if you said it was for urination, then the insurance had to pay for it. Now you end up with your erection medications. These days, if someone says I have problems with, and so if you say I have problems with my erections and I'm sort of about my urination, it is an excellent one-stop shopping. You can treat your urination and your erections at the same time, but just realize that the dose of Cialis that you're using for urination oftentimes it's not nearly the same dose as you might take if you were taking Cialis on your own. So that's the answer to that. Now it's super cheap. So actually, you don't tend to find many people doing daily Cialis for those reasons, but it does treat BPH. It is FDA approved. It's not quite as good as the alpha blockers. The next question is, are there any drug interactions between with the alpha blockers that we mentioned or the 5-alpha reductase and tadalafil? No. Generally, they work completely differently. Alpha blockers relax the smooth muscle in your prostate. 5-alpha reductase inhibitors block a certain conversion to a form of testosterone, and that's what makes the prostate wither. And tadalafil works differently as well, but it's more of they're not really sure how that works, to be honest with you. It's a vasodilator for erections, but so no, Cialis is not an alpha blocker. There's a question here, tadalafil, but you can definitely use these three. So I've had patients come in saying I'm on Flomax, I'm on daily Cialis, I'm also on finasteride, and I'm on saw palmetto. Now that's not going to be my patient, and they will not have gone to my website or seen my webinar, because why would you possibly take 4 medicines that aren't making you happy when you could at least try a 5-minute procedure with little risk? So I don't really see the logic in that, but that's not an uncommon thing, and they don't interact with each other. How do you access, so it says, can you still use tadalafil after surgery? Absolutely. The goal of surgery, by the way, is if it works, you're not going to need medication to help you urinate. But if you're taking it for erections, absolutely. Well, these are two separate issues, and so that hopefully answered that question. How do you assess, I think it should say, it says access, but I think you mean, how do you assess the size of the prostate to determine the best procedure? And the answer is yes, I always do cystoscopy. Let me tell you why I do that. It asks, do you do a transrectal ultrasound? And the answer is rarely. The only time I'm generally doing a transrectal ultrasound is when I'm thinking we're in the zone where we're going to start talking about the big prostate menu, robotic simple prostatectomy or HoLEP. And there I don't want to get surprised when I'm in the operating room. So there I might do a transrectal ultrasound just to show myself that it's over, say, 100 grams or so. But really how I'm going to assess the anatomy, because it's not just size. I was simplifying that before. It's size plus anatomy. And how I'm going to do it is a cystoscopy in the office. I do that for 2 reasons. I do that for 3 reasons. The first is I want to see the anatomy. I generally do it where I say to patients, I want you to decide if you want to do something else. It's not up to me, but it's up to you. If you want to do something else, think about an office procedure or think about a procedure. I say, go to my website. It's very extensive. You'll learn about all the things on the menu. I do the scope, and then I say your anatomy is best suited for X, and it's usually an office procedure. So I can tell how big your prostate is by cystoscopy, and I can also tell if you have a certain anatomy called a middle lobe. People with a really big middle lobe don't do as well either with office procedures. So there's times where they may want an office procedure, and I'll say, look, I just got to be honest with you. You're going to have about a 60% chance with this, but if you do a TURP, it's 95%. So it's a cystoscopy is my workhorse to say, what's your anatomy? What's the size of your prostate? Next question, what is an indicator that Rezum did not work well? And what would be the next procedure if a Rezum fails? Well, we talked in the lecture about how do we assess symptoms, and every urologist uses this survey called the IPSS, or International Prostate Symptom Score. And that's how you get FDA approval for drugs. You have to show that that score gets reduced more than sugar pill reduces. And by the way, sugar pill reduces it a lot. The placebo effect of things is very high. I actually had never had a patient come in and say that it's the same or worse after a Rezum. they'll either say, man, this is great, this is incredible, this worked, like this really worked, or they'll say it worked a little, which in my opinion might be the placebo part. So the indicator that the Rezum didn't work well is generally whatever symptom was annoying you that caused you to ask me to do a Rezum. If we didn't solve that problem, then by definition, it didn't work well. Almost uniformly, the patient will say, I urinate stronger, you relieve some of my obstruction, but no one complains about their stream. Patients are not going to complain about their stream. They're going to complain about the annoying thing that got them to ask me to do it. I get up at night. I'm going urgently. So the bottom line is, if you're not happy, if you're not happy and I didn't solve that problem, that means it didn't work. But when a Rezum doesn't work, I'm going to pay a lot of attention to that survey to say, have I solved all of your obstruction problems such that now all you have is overactive bladder problems? Sometimes what the Rezum does is it's going to take away the fact that you're obstructed and just uncover that the real issue here was just that you had an overactive bladder. I've not replaced your bladder. And now you're no longer obstructed, which means I'm free now to treat you almost like I might treat a woman, where I might give you more overactive bladder medications, those medicines we talked about in the Alzheimer's question, anticholinergics, or things like Myrbetriq. There's another drug called Gemtesa. So that's how you know. This patient has an artificial mitral valve. And can this be a deciding factor for any of the treatment options? I would say the following. I mean, if you have an artificial valve, it's not going to be something that we're so worried about seeding the valve. Infection, I think, is not so much of an issue. We do put you on a bunch of antibiotics. The only way that's going to affect our discussion here is what kind of artificial valve it is. Every now and then, not used very much, it tends to be what's called a mechanical valve, which is metal, which means you could never go off blood thinners. We can technically do a Rezum on blood thinners, actually. You can't, the operating room procedures are no good on blood thinners. So in general, I'm going to tell you that a mitral valve is not going to affect these treatment options. It's just something we should know about. What blood thinners do you take? If you're still on them, what are we allowed to do with that? But we are actually able to do some of these procedures on blood thinners, but we're usually going to want you to at least lower them some so that we don't have a bleeding problem. But that's not an excluding factor. Here is a question that asks me, is there any scientific basis or correlation for individuals that have an enlarged prostate, whether those patients with an enlarged prostate, maybe 5, 10, or 15 years later, will develop prostate cancer? The answer is no. The answer is basically no. It's such a studied topic, and people have tried to find that link. But in general, the simplistic answer to that question is no. The process that we don't totally understand, where your prostate, the benign tissue in your prostate just starts to grow as you get older. We don't entirely understand that. I mean, it's because of the changes of the forms of testosterone in your prostate as you get older. That's just a completely different mechanism than the evolution of cancer. So let's just say there isn't a correlation. Maybe I have to talk to patients all the time about they're anxious and they're worried because their PSA level has drifted up and their PSA level is higher. And that's explained by benign tissue and an enlarged prostate. If you want to become an expert on that, I have a webinar on my website about prostate cancer screening. But one is not causative of the other in any way. The only overlap tends to be a bit of a PSA discussion. Oh, and well, actually, the next question segues right into that. What is the relationship between BPH and PSA levels? So what's the relationship there? Again, the relationship is just that both that cancer and enlarged prostate raises your PSA. But what my talk that I just mentioned about is why I rely on PSA trends to tell you what to do about that. The trend of enlarged prostate tends to be, I call it the plane leveling out at 30,000 feet. It tends to be, as it grows, it starts to rise. So if a patient sees me with a rise within the normal range, I'm going to say, look, this is just because you're join the club. You're starting to notice that your prostate's growing a little bit. And a lot of times the PSA rises before you start to notice the symptoms. But if that's why the PSA is rising, even if it's 5 or even 6, it should start leveling out at some point and then start going like this. That's the trend of enlarged prostate. That's where we went wrong for 20 years, biopsying guys because their PSA was above 4. We were just biopsying enlarged prostate. We were biopsying aging, to be honest with you. Cancer trend just keeps going. So the relationship is the bigger your prostate, the higher you're allowed to have a PSA. That's the term for that we use is called PSA density. There used to be a point where we would actually do an ultrasound of your prostate and make a ratio to say you're okay. These days, a rectal exam works just fine. You don't need to go through that. You don't need to go through an ultrasound. I mean, generally, an experienced urologist is going to tell you how big your prostate is with this complicated instrument here. This patient's asking, who do I refer patients to for HoLEP? And so again, HoLEP for me is something that you would consider if you're saying I have a huge prostate and for whatever reason I don't want a robotic simple prostatectomy. They at meetings they'll commonly have point counterpoint, arguments between two people that there's usually no clear winner between the two. There's pros and cons. I can tell you that, and I'm now I'm going to be putting this on the internet. I certainly can tell you that Gaurav Bondi at Georgetown has been doing HoLEPs for a very long time. So that is somebody that I do commonly do. That is something where there is a big steep learning curve, just like with robotic surgery. And you want to see someone that's done a lot of them. I'm sure there's other people around now, very much so, that do these. This is a good niche to have, a HoLEP. So, and again, just pointing out, it's not something I couldn't learn to do. It's just, for me, there's no clear winner. If you go to my website, you'll see I'm pretty experienced with robotic surgery. So for me, the go-to procedure is the robotic prostatectomy because I've done a million of them and I do them well. But historically, I've sent people over to Georgetown for the HoLEP, but certainly I know there's people in Northern Virginia, and he's not the only one anymore around. So here we're going to talk about, someone's asking me about an off the topic thing. I'm going to answer it because I promised I would, but we're talking here about erectile dysfunction. So I give these talks all the time. We're about to post my erectile dysfunction talk and Q&A on my website. It's not there. So maybe I'll just defer this. I'll read the question. They're talking about injections for erections. That's called trimix. They're asking, what's the highest potency? It's not a function of whether there's 3 or 4 medicines. It's a function of how strong the solution is. This person's asking about injections for erections and penile implants. So I'm going to go off on too much of a tangent to go there. How about first you go to my website at dcurology.net. You're going to learn all about that. Trust me. Very soon you'll see a long webinar and a Q&A on that. I'm going to answer everything about penile implants, trimix, pills, shots, you name it. So let's just do that. Oh, thank you. There's a great question. And again, it wasn't part of the slide, so I would have been off on a tangent. It's already weird for me to go through a talk and talk about what I would say and not have it be there. Let's talk about a procedure called aquablation. Because actually, if I was talking about aquablation, we're going to talk about aquablation. What is it? If I could make my own slides, I certainly would have an aquablation slide. It's very much represented on my website in my soliloquy there. I mentioned that if you have a really big prostate, the smart move here is to choose either a robotic simple prostatectomy as a minimally invasive procedure or a HoLEP. I don't discount the HoLEP. Aquablation is a third procedure that was popularized to address really large prostates. I've already mentioned that there's a very steep learning curve. It's a very specific skill set in urology to do a robotic simple prostatectomy or a HoLEP. And what that means is there's generally only going to be a couple guys, 2 or 3 men or women in town that are going to be good at doing that. And so what if you're not one of those urologists? What if you want to help your patient and your patient doesn't want to leave you? What if you have a great relationship? Well, aquablation came in What it is if you all can remember, and some people still use these, very popular used to be the water pick, instead of floss, this water jet that does a good job of cleaning between your teeth. Well, it's that times 100. It's a super fine water pick jet. And it is a truly autonomous thing where you set the device, you take an ultrasound of the prostate, you kind of tell it how deep you want the jet to go. And then it just does this sort of rapid, shooting this as a way to destroy the tissue. It can destroy a big prostate tissue, and it suddenly was a tool that would allow urologists that really can't do a robotic simple prostatectomy well, or a HoLEP, to offer a solution there. People are starting to do it for even smaller prostates now. You can't do it for much smaller because it has risk, and there are risks to an aquablation. The reason I don't favor it is just because there's a lot of bleeding associated with it. There's a big take back to the operating room because the patient's bleeding a lot and they're in shock. And to me, that's just something that's not acceptable in my patient population. I don't have to accept that risk because I can do something where that just doesn't really happen. So that's what aquablation is. It is growing in popularity. I know some groups that are starting to do another procedure I didn't talk about, so I'd like to talk about it now, called prostate artery embolization. That's a procedure that has been marketed to be a minimally invasive procedure. It's to me much more invasive. It's an angiogram basically of your prostate. They're plugging up the arteries to your prostate. It at most works as well, but it doesn't really work as well as the office procedures we've discussed today. It has much worse complications that can occur, prostate artery embolization. So I don't advocate it. An interventional radiologist would do it. And generally, I have found that patients that do prostate artery embolization, they tend to find that solution on the internet, and it sounds great, but it doesn't work very well. And I don't think there's a lot going for it, but it is out there. What I was going to mention is that there are some groups that what they'll do for their patients to address the bleeding concern is they'll do a prostate artery embolization as a separate procedure, and then they'll do an aquablation. Again, that's just something that's overly complicated for something that I am pretty facile at solving with robotic simple prostatectomy, but that's what an aquablation is. That's an overnight hospital stay as well, just like a robotic simple or a HoLEP. And I initially said that, here's one that says, I initially said that a TURP interfered with ejaculation, but later said orgasm. Thank you so much for correcting me. I said orgasm because the slide used the word orgasm. No, it does not make you not have an orgasm. It just like the 15 or 20% of resumes, you'll have an orgasm, it'll feel good, you just won't shoot semen out. They call that retrograde ejaculation with a TURP. It's not really that. True retrograde ejaculation is that the semen, the prostate's no longer working as a junction valve. So the semen goes in, but then it goes backwards. It's only really retrograde ejaculation if then you see yourself urinating out the semen the next time you urinate, and it doesn't really happen. I call what happens there similar to what happens with the resume. It's coelomeals. I hope you all know what that is. It's an old device to freeze things. It coelomeals or fuses the little ducts where semen drains in. So no, it does not take away orgasm. Thank you so much for pointing that out. And I know why I made that mistake. Excellent question. Next question. If someone's had a prostate cancer treatment called brachytherapy or seeds, which really this would be the same question for almost all forms of radiation. Would that affect this? Would I maybe not offer some of these treatments to those patients? And the answer is, I offer the same treatments to those patients. Those patients will have, I have to rule out scars and things like that. I have to make sure there's nothing else with radiation involved, but it's the same thing. If they seem like they're blocked, if it's not just overactive bladder symptoms, I certainly will try the same, and I've had great results. Same progression. And that's actually reminding me, I think I went off on a tangent. I do cystoscopy to determine the size of your prostate before and off any procedure. I think I mentioned 3 reasons. One was to determine anatomy. The second was to avoid surprises. Don't want to find that you have stones in your bladder. Rarely, I'll actually find a tumor in your bladder that could have been adding to urinary symptoms. And the third reason I do the scope is because I want to show you how easy that is. If you just follow my lead, that way I don't want you to be nervous on the day of the resume. I just realized that I didn't finish that thought. So there you go. So no, if you've had brachytherapy, as long as the problem isn't a scar, then that is not a contraindication at all to moving forward with this. There tends to be a little bit lower success rate because maybe the tissue is somewhat scarred and somewhat just enlarged, but no, it's worth the try. Now, that's not true of operating room procedures. You have to be very careful about doing an operating room procedure where you're shaving out tissue or that kind of thing, because the incontinence risk is far more than 1% if a person's had radiation before. So that would affect my advice on that one a little bit if we weren't talking about an office procedure, but there are not higher risks with an office procedure. And then at this juncture, these have been great questions. Thank you so much for firing this and firing away. And this is going to make for a great recording and help a lot of people on my website. By the way, I'm told I get 40,000 hits a month on my website. And I'm sure that many of those people don't live in town and they're just using my site for educational purposes. So that means a lot to me. So this last one's a long one. I'll read the whole thing. This patient had a resume in 2018 in Baltimore. So I was thinking, I don't think I was doing them in 2018. And this person had some bleeding afterwards and some catheter problems. Maybe their catheter was getting clogged up, etc. A week later, they had to go to an emergency room after they placed the catheter, and there was a certain pressure sensation in the prostate ever since. That the urine flow improved a little, but it didn't solve the problem. Okay, so and again, they're talking it was very painful during the procedure. I understand that. I'm actually asking Boston Scientific to ask me to make a movie of how I do my numbing thing. I actually learned the modification from how they want you to do it, and then I added like a few other things. So I think the answer, this person is asking, maybe they're asking, what to do. That prostate massage helps, and that this didn't really help. Well, I think I'm going to address that is this isn't one size fits all, but maybe you remember me saying, a lot of times if the resume is not working, if it didn't solve your problem, maybe it wasn't an obstruction problem to begin with. This person is this person is just saying, this person in this long question is, by saying prostate massages help and things like that, this speaks more towards, did you have a pelvic floor issue? We used to call that prostatitis. Now we generally think that's your muscles down there are all tight. Was the resume misguided? Was it really an obstruction problem? So this is someone I wouldn't necessarily be jumping into talking about a resume. It didn't really help before. And this is something where we would look at that IPSS score and really get a sense a little bit as to say, was the resume going after the right thing, or is this more of a prostatitis? That's what we called it in the old days. Today we call it pelvic floor dysfunction. So that's kind of a hard one there. And here's someone saying, I can ejaculate, but there's slightly less semen. Maybe that's someone who's had a resume and they're just, oh, that's the same patient here. So that's probably a harder one to answer in your particular case. That one's probably going to have to be, maybe you get with me, let's do a telemedicine or see each other in person, and I can try to help you there. That one's a little more complicated. Okay, any more questions? That was plenty, and that pointed out all the things I forgot to say in my slides. And if there are no other questions, I'll wait maybe 30 more seconds just to make sure. But I hope everyone has enjoyed this. I'm trying to do an ongoing, I try to add more and more talks to this. Some of these are, Boston, I work with Boston Scientific a lot. They are the people that make the devices. to fix incontinence in my practice. They do penile prostheses. I do a lot of these resumes. I'm not a big fan of their green light laser thing. But my favorite talks are the ones where I make my own slides. So coming soon, or maybe there now, there's a talk about how do I counsel people through if they're told they have prostate cancer. You will see this put up shortly. You will see one about erectile dysfunction, and then a question and answers there. So I'll keep adding things. I might do one on kidney stones next. So hopefully you like it, and it's part of an ongoing series. And if you need me, you know where I am. dcurology.net. Happy to talk to you and hope to see you in the future. Thanks for coming, everybody. I'm gonna, looks like we're done here, and I'm gonna end it now. Thanks again.